Thanks, Ling, for the introduction. Today I'm going to talk about nuclear scintigraphic assessment of cerebrovascular reserve and brain death. First of all, I'll just briefly talk about the two different types of nuclear techniques we use for imaging, both computed tomography techniques. The first one being SPECT, which stands for Single Photon Emission Computed Tomography. So if you see from this diagram, after we administer the tracer into the patient is actually emitting the photons in all directions. And how we actually gather information is to use these collimators, where we will have the collimator in front of the detector, and then these collimators will actually rotate around the patients for cross-sectional imaging. And these are some examples of SPECT images that we can actually fuse with CT if it's done on a hybrid machine. The other technique is actually PET, which stands for positron emission tomography. It actually depends on coincidence detectors, because when the positron actually is emitted, it will quickly annihilate with the electron and give out two 511 keV photons in opposite direction. And by detecting these coincident photons, we can reconstruct the origin of the emission event, right? So it's also usually done together with CT or MR, and we can fuse them together, like in this example. So today's topic is about cerebrovascular reserve. So mainly in internal carotid artery stenosis, there have been randomized trials that were published that actually showed that direct ECIC bypass surgery did not reduce consequent strokes when compared with medical therapy. And hence, it was proposed that, we do baseline and acetazolamide sort of like a pharmacological stress SPECT study to evaluate the hemodynamic significance of steno-occlusive lesions in ICA and cerebral arteries in a way similar to the myocardial perfusion imaging that we've been doing for decades to look at the functional significance of occlusion. Vascular reserve impairment in carotid and cerebral artery territories is proposed as an image biomarker for decision to decide for bypass surgery instead of medical treatments. And the radiopharmaceuticals that we use, there's mainly three. The most common one being technetium-99m HMPAO, which is what we use in our department. The other one being TC99M ECD. Both of them are similar. And there's a third one, iodine-123 IMP, which is currently only available in Japan. These are actually lipophilic agents that can cross the blood-brain barrier and has a high first-pass extraction fraction. So for HMPAO SPECT, they have shown that outcomes for patients are generally poorer if they have already had infarction, patients with younger ages, whereas in patients with decreased vascular reserve but preserved basal perfusion, they can actually have good outcome. And these are from this paper, a meta-analysis of surgical outcomes of symptomatic moyamoya disease in adults. In these subjects, right, they have shown that bypass surgery actually improved stroke prevention. So we'll talk about the pathophysiology of cerebral ischemia that's revealed on SPECT imaging. In carotid or cerebral artery stenosis, the basal perfusion actually can be normal because of the compensation of brain vessels. And so what we do is we give a pharmacological stress, which is in the form of acetazolamide, which inhibits carbonic anhydrase and hence increase the carbon dioxide pressure. In the early stage, when the ischemia is compensated, the cerebral blood flow is actually complemented by capillary recruitment as well as vasodilatation. And there's resultant increase in the cerebral blood volume. And this is what we call the cerebrovascular reserve. And by challenging with acetazolamide, it discloses the difference between normal and a decrease in vascular reserve, as shown in this diagram. So when it's in the compensated phase, right, the basal CBF can be normal, but if you administer a pharmacological stress, right, you can show that there's actually a decrease in the vascular reserve. So actually, the threshold for impaired vascular reserve is not exactly a one-to-one matching with the anatomical percentage of stenosis as well as the functional consequences. It depends on the chronicity of the stenosis, the length of the stenosed area. Sometimes the atherosclerotic plaques can be eccentric, or if they are vulnerable, they can rupture and cause an acute event. There's also compensatory collateral formation, which is especially high in children with Moyamoya disease, and also the fluid dynamics, which sometimes is different from what we see on morphologic imaging. So they propose that the optimal time for intervention is actually when the CBF starts to decrease despite the increase of CBV and or the oxygen extraction fraction, the OEF. Basically before the state of no help from any medical or surgical interventions. And with the same degree of stenosis or occlusion, there can be a diverse status of vascular reserve for individual patients, and some will have an aggressive course, whereas others will have an indolent course, and depending on the formation of collaterals. So we have been actually using acetazolamide for a long time, but there are actually side effects and safety concerns also of this pharmacological intervention. Contraindications include allergy to sulfur drugs, patients who had acute stroke or recent intracranial hemorrhage, and there have also been reports that there could be mortalities from Dimox due to acute pulmonary edema. This has been reported to have 8 cases in Japan after 20 years of annual caseload of 20 to 30,000 procedures. And there was also a report of extensive brain infarction in a teenager with Moyamoya disease, probably due to a steal phenomenon when we administer the acetazolamide. And there are also a potential of doing quantitative assessment with tracer kinetic analysis using the padlock plot with arterial sampling at 10 minutes. For this technique, the HMPA-O spec is the preferred choice. The cerebral blood flow of normal brain, normal human cortical brain was estimated to be about 50 ml per gram per minute. And after acetazolamide infusion, it can actually increase by up to 50%. So this is actually an example of a case before and after bypass surgery. Right, so on this case, on the Dimox stress image, you can see that there is decreased perfusion in the left, basically the parietal occipital region. That was actually normal on the basal image, right? So this is a case where actually the pharmacological stress causing the vasodilatation of the blood vessels show that there is a reduced cerebrovascular reserve in this region. And after surgery, they follow up with another set of basal versus Dimox scan. And they show that this area actually showed improved perfusion on Dimox stress. So on activation, actually regional brain tissues can enjoy a 20% increase in cerebral blood flow. And in cases, 10% increase in the cerebral blood volume in a steno-occlusive state. And the median transit time is prolonged to support the CBF. On Dimox challenge, since the blood flow can actually increase up to 50%, it actually mimics a severe global hypercapnia situation, and it's actually testing the limit of the vascular reserve of the entire brain. And so it discloses the area of insufficient vascular reserve, which will happen as a steal phenomenon with hemodynamic significance. So this will suggest candidates for further treatments, for example, stenting, endarterectomy, bypass surgery, or in some cases, just a best medical treatment. So I'll switch gear to talk about nuclear assessment in brain death. Brain death is actually defined as the irreversible cessation of all functions of the brain, including the brainstem. It's actually primarily a clinical diagnosis when patients had coma, absence of brainstem reflexes, and apnea. But on occasions, ancillary testing may be required when the clinical criteria cannot be satisfied. For example, if patients are sedated, if patients are under drug intoxication, in hypothermia, neuromuscular paralysis, severe hemodynamic instability, as well as significant electrolyte imbalance. So there are actually several methods of ancillary testing for brain death, including cerebroangiography 4VA, which is the gold standard. People also do EEG as well as transcranial Doppler ultrasound. And sometimes they do cerebral scintigraphy, which is what we call a nuclear medicine brain perfusion study, using the tracer that I've mentioned earlier, HMPAO or ECD, using planar or SPECT imaging, depending on availability of the machines. In some centers, for example, in the US, they do a DTPA planar image, which only allows assessment of the flow as well as a static anterior-posterior images. The drawback of using scintigraphy being that availability is limited because it's not round the clock, because usually the hot lab preparing the doses do not work 24 hours a day. And also it's time consuming because you need to actually prepare the tracer and then send the patient down with staff support and do the scan. This is actually a graph showing the retrospective records from Cleveland from 2010 to 2020, showing the etiology of brain death by age. Traumatic causes being more common in the younger age group, whereas intracerebral hemorrhage are more common as the age group increase. This is a simple diagram of a case of brain death on a nuclear medicine perfusion study. Brain death means that there's no tracer uptake in the brain, including the brain stem. There have been studies comparing CTA with perfusion study on nuclear medicine in 25 subjects with multiple injury patterns, and they show that actually CT angiography, when compared with the nuclear medicine perfusion study, shows sensitivity of 0.86 and a specificity as good, which is 1. So on this planar image, you can see that in the early phase, right, you see the tracer flow injected, and then the bottom one is the brain death study. The top one where you see normal cerebral blood flow as the tracer is injected, you see tracer going up the cerebral arteries, the carotids, and going into the brain. Whereas in the brain death case, the brain, you can see scalp uptake, but then intracranially, there's a void. And this is in keeping with the brain death. And there have been actually a paper published last year talking about all the ancillary testing used in protocols around the world. So including conventional angiography, CTA, MRA, nuclear medicine flow studies, transcranial Doppler, as well as EEG, right? So Singapore is here. So in the protocol 4VA, as well as a nuclear medicine perfusion study, are included in the protocol. So what we normally do in brain death, we acquire flow images, which is dynamic images, and then static images in the AP as well as the lateral view, where we typically show a hollow skull or what we call an empty light bulb sign. And sometimes we'll see a hot nose sign because of increased activity around the nose that's supplied by the external carotid arteries. And if available, we'll do SPECT imaging for better visualization of the posterior fossa, and that is routinely done in both SGH campus and TDSH campus. So with that, that's the last slide. I'll conclude my